Hi everyone, and welcome to ABC's of Anesthesia. And today I've got with me Dr. Lee. We're going to go through some exam practice for your RGA assessment that's coming up. Lisa, tell us a bit about yourself.
So I'm a rural generalist trainee, currently working in Orange, New South Wales. Trying to complete the Viva component of my RGA training. I've had a few struggles in the past, mainly focused on technical and structural issues in my responses to answers that have been compounded a little bit by the format, and hence reaching out in this sort of structure is good to practice on a Zoom format, which is similar to what we'll do at the exam as well, which I think is slightly different to most fellowship training now. In sort of the subspecialty regions have reverted back to in-person training. So it's just the GP training colleges and our sort of advanced skills training that is done via a Zoom format. So I'm just trying to get my head around it and bring in a few of my sort of intricacies that have sort of led to a few challenges in the past. And I think trying to address those by more practice with more people and getting a critique of my performance is going to improve that sort of thing come exam time.
Yeah, that's great, Lee. So I'm so happy you reached out, because I think that's exactly what I'd do. You just want to ask as many people and just try to get as much practice and feedback and just get those runs on the board, just get that practice in. Full disclaimer, so I am an examiner for the RGA, and so there's potentially a conflict of interest there, but I just want to say that I've written questions, but the questions I'm going to ask you are definitely not the ones I wrote. So I have no knowledge of the exam, and the way we're going to go through it is very general. Like a lot of the stuff in this RGA Viva type exam is, there's no tricks to it. It's not like in the final exam that we do for ANSCA, there's some really niche situation, but we're definitely not doing that in the RGA. So it's very much the basic template. So, this information is the stuff I'd teach anyone at any time, regardless of whether the exam's going. Also, just to give people a bit of a background for the RGA, so we recently changed the format. It used to be the JCCA, and now it's different tripartite agreement with different colleges, and there's a lot of different parties involved in writing every exam question. So it goes through a lot of really stringent kind of testing and quality activity. That said, there's lots of variations in the people that write the exam questions, and so I'm going to try and give really good general information and specific advice on how you're presenting stuff the way I see it, and hopefully that helps. Yeah, beautiful.
I appreciate it. Appreciate your time.
No worries at all. Hey, so just for the audience, so it's like a 2-minute STEM and then a 13-minute exam. So the STEM I'll just read out to everyone. It's 28-year-old male presented with right lower quadrant pain for an emergency appendicectomy. There's a Scenarioville is a particular environment that you guys will be in, and it's and all the RGAs know what the definition of that is. But essentially, it's kind of like apparently being in Port Lincoln in Australia, where you've got certain specialists but not super subspecialties. You don't have, I think, do you have a HDU?
No HDU from the format that I've looked at. It has been updated for this most recent one. I think there's still no HDU ICU component. So
beautiful. So just imagine there's no fan curves, you've got your RGA colleagues and skilled nurses, nothing's too specialized. And if you need a transfer out, there's a center X kilometers of distance away. So here's the situation. So for an emergency appendicectomy in Scenarioville, past history of asthma, the patient is 120 kilograms with a BMI of 38. So that's about 175 centimeters tall. What do you want to know in assessment is the question. So take it 2 minutes. And everyone else can have a think about this if they're online. Yeah, that's 2 minutes. Okay, Lee, and we'll try to make this as kind of formal.
What do you want to know? The answer is possible. So with my assessment of this 28-year-old male for emergency lap appendix on background of asthma, who's currently fits the category for morbid obesity. In Scenarioville, I've got to take into account what services and outcomes are available. But specifically to this patient, my assessment would focus on history, examination, investigations that are available to myself. So on the history, I need to get a quick situational overview and handover from the surgical registrar or the consultant booking the case to assess how long they've been unwell, the transition to clinical signs. So is this a clinical appendicectomy with rebound tenderness, Robson's positive signs, or is this imaging confirmed?
Let's say it's some clinical appendicitis.
Yeah, the clinical appendicitis. We've got so we've got a clinical assessment, emergency situation. So we're going to sort of proceed through our case and get a quick, ample history for this patient. So covering allergies, past or current medications, especially for his history of asthma, whether or not his asthma is currently in an acute situation, which we might have to pre-medicate prior to anaesthetic. We're looking at past surgical and anaesthetic history and whether or not there's other indications. So his smoking status, his alcohol consumption, and his other drug use as well, so recreational drugs. Whether or not he's last had something to eat, whether or not he's been unwell. This is still a situation of an emergency case, and I would be working through an RSI planning further. But this is sort of where I'd come down to, and then I'd then progress through my airway assessment to check whether or not this gentleman's going to be difficult bag mask, difficult LMA insertion, or sort of a difficult intubation for this case. I prepare my theatre. Let's focus back. Yeah. So still on assessment.
Anything else for asthma?
Asthma, acute flares, any ICU admissions that have been required retrieval from Scenarioville to a larger centre, or hospital admissions to Scenarioville Hospital. I need to know his regular medications. So is he only on a salbutamol puffer? How often does he run through a ventilator inhaler? Is he on preventive therapy, or is he on and does it flare up? What are some of his triggers that he has? So we'll limit a few of our medications that we may require for this procedure. Anaesthetic history, has he had any previous operations? If not, is there any family history of complications with anaesthetic? And even if he has had a procedure, this is the first time meeting this patient. If I'm in the area or just haven't had any surgery for him, I'd be asking those questions as well. Other medications.
I'll stop you there.
Yep.
So just to give you, and in the exam, we're specifically told not to give you too much information because it's a lot to take in during a stressful situation. So you correctly asked some things. The high points of this are clinically confirmed appendicitis. Vitals are stable. Asthma was reasonably well controlled with minimal flare-ups, just on Ventolin, PRN, and otherwise, that's probably the nuts and bolts of it. What do you want to know in your airway assessment?
So with my airway assessment for this patient, I need to know whether or not he's going to, so again, working through my process of ventilation, so pre-oxygenation and bag mask ventilation if required. We've got whether or not he's a suitable LMA if we need an emergency airway. And then we've got our ideal procedure for this is going to be an RSI with an intubation.
I'm going to ask the question again. What do you want to know on your airway assessment?
What do I want to know on his airway assessment? So I need to know if he's had a previous difficult intubation or airway issue in the past. My airway assessment is going to have a general appearance. Does he have a beard? Has he got a sort of a very pointed face? Has he got a retrognathic jaw? Does he have any sort of facial appearance that would mean he's difficult to ventilate? I know he's obese with his weight, and it's going to be a difficulty. I need to know his dentition and size of his tongue. I need to have a look at his Mallampati score and mouth opening, interincisor distance. thyromental distance and neck extension as well, whether or not he's had any sort of obvious surgery or trauma to his neck in the past that may cause any deviation or airway concerns that are, so for deformity.
So the information you've gleaned from that is he's got a beard. He's no previous anesthetic, so no past history of airway management. All your assessment features are normal, except for the fact that he's got a beard and his weight. When you manage an airway, if there's a difficult airway, what approach do you use to a difficult airway?
And I'm going to sort of get that sort of question. So my approach to a difficult airway is, again,
an unexpected difficult airway.
An unanticipated difficult airway is going to sort of work through the vortex sort of model that would sort of go through.
So can you outline the basic principles of the vortex model?
So the vortex is ideally optimizing to return patients to a green zone and a period of safety, maintaining a maximum of 3 attempts at any one rescue. So that's avoiding a can't intubate, can't oxygenate process and maintaining oxygenation for the green zone. So the 3 subgroups for this are bag mask ventilation, supraglottic airway devices, and intubation, ideally using no more than 3 attempts at each pathway. Again, then with the insertion of the game changer. So is that adding someone new? Is that adding a new piece of equipment? Is that, is there someone more experienced airway support to come in that situation, or the use of a paralysis across the 3 as a sort of an element of producing optimal situation to return to the green zone and maintaining oxygenation to avoid front of neck access, emergency front of neck access. However, the purpose of the vortex is to create a shared mental model to keep everyone and providing that stepwise approach to taking away the decision.
What are the stepwise approaches in the vortex approach?
Ready, set, and go.
Forgetting that one, we've got the vortex itself. What are the details of, when you're doing each lifeline, what are the details of managing each lifeline?
So managing each lifeline. So again, I'm just going to try and sort of go through those things. Starting with bag mask ventilation, 2-handed technique or 2-person technique for mask position, change of mask size, optimizing the sort of the avenues across. So position is one. So making sure they're in the right adequate position. And I think I'm sort of missing this situation as in lifelines being, so manipulations, device, paralysis, and working through a stepwise approach to have 3 different changes.
I agree. What are the, I guess, manipulations or adjuncts / devices you could use for bag mask ventilation?
The bag mask ventilation. So positioning, getting them into an adequate,
keep going.
So sniffing position, and so again, so trying to pieces to bring it back. But adjuncts being correctly sized oropharyngeal airway, nasopharyngeal airway.
What are the manipulations?
Jaw thrust. So to get optimal position, so you want to have tragus.
That's actually perfect. Jaw thrust is fine. How about LMA? What are the things you do to optimize, I guess, LMA?
So optimization for an LMA, again, positioning, the change of size of an LMA. So from a 3 to a 4 or a 5, depending on the size of the patient, the mouth aperture and the neck, or change of device from a first generation classic or to a second generation.
I'll stop you there. How about for intubation? How would you change that?
So intubation is, so again, optimizing position to the correct intubating position, so sniffing position, ramping for a morbidly obese patient. So other adjuncts for use are video laryngoscope, change of size of the blade, and then bushing and stylet. We've also got second operator, so use of external laryngeal manipulation or BERT.
That's great. Now, let's say for this patient, you know the age, the weight, 120 kilos. You're doing a rapid sequence induction for them. What drugs would you use for this induction?
So my induction drugs and medication for this patient in this situation, knowing that he's obese and possibly going to be a difficult oxygenation situation, I want to, but we also need to make it safe. So we need analgesic. So in this case, I would probably go with fentanyl. Dose-wise, he's 120 kilos. I'd probably get 500 and work with 150 to 200 milligram dose.
Microgram?
Microgram, not milligram, microgram dose. Yes, sorry.
Yeah.
And then, so given there's no past history of concerns that we're aware of, propofol, we are aware that he's got asthma, so we may need to sort of provide an adjunct and use of ketamine in this situation as well, which may improve his respiratory drive. But at this stage, we're going to go 2 milligrams per kilo of propofol. So again, 200 to 240, whatever's available within context. And then an intubating dose of, so again, the original setting of
how much
dark spurs. Sorry.
Just tell. So I'd say.
Oh, okay. So then my paralysis agent would be rocuronium at 1.2. So 1.2 milligrams per kilo, 120s. You're looking at sort of 150.
Great. Let's say you do the induction and everything goes well. So you do the induction, everything goes well. You put the tube in. And as you try to bag mask the patient, everything's going well. You listen to both lungs and the tube is in the right position. And then 5 minutes later, you notice that the SATs were at 99% and now they're at 90%. You've set the monitor up in whatever way you normally set it up. The FiO2 is on 60%. You're running SEVO with volume control ventilation settings. And the SATs fall to 90%. What do you do?
So I'm going to recognize that on the monitor and temporize by turning the FiO2 back to 100% and flows to maximum, so 10 to 15 litres. I'm going to assess the progress for that sort of change whilst I'm sort of working through my assessment of starting at the patient. Given he's got a background history of asthma, I'm going to start at the patient and work my way back through to the machine. But also, I'll go back a step, sorry. As I'm recognizing that change, I'm also going to perform a machine check as I'm changing my settings on my ventilator. So you're looking at heart rate, blood pressure that may alter our differential diagnosis and look at things. So if there's hypotension and a tachycardia, we might...
Everything is normal on the monitor except the SATs.
For the saturation. So I'm turning the FiO2 to 100%. I'm turning the fresh gas flows from where they are to 10 to 15, maximum setting available on the machine. And I'm going to have a quick assessment of the patient to check whether or not they've got central cyanosis or they're to change colour, and have a listen to their lungs in the axilla to check bilateral air entry. Listening again for a wheeze because that's his background.
You listen and you have quite loud wheeze on auscultation bilaterally. What do you do?
Right. So at this point, I'm going to, if the surgeon's starting and I have all that, 5 minutes in. Right. So we've got a loud wheeze. I haven't provided antibiotics. I've given, other elements, I'm going to provide salbutamol in line with the correct position and orientation of the flow meter as 12 sprays with the ventilation. I'm going to check pressures on the ventilator as well. If they're higher, if that's the case, I'm going to switch to a bag ventilation and check to see if they're real pressures in his lungs. I'm going to Um, and and then consider drawing up other medications for rescue as well. So adrenaline in the sense for working through my algorithms
Else,
and
let's
differentials.
say, how many,
Atrovent,
how many puffs did you give a Ventolin?
12
Yep.
sprays as meeting the
What are all the other agents you could give to treat
so,
bronchospasm?
so bronchospasm we can use adrenaline IV, we can use IV salbutamol, we can also use IV magnesium, and then steroids is probably not going to do a whole lot acutely, but in the setting of recognition and treating, we could use some hydrocort IV if I haven't given the dexamethasone as pre-medication.
And I heard you mention Atrovent there as well.
Yeah.
Let's say after 12 puffs, you still have some wheeze there, but it's got a lot better. How much Ventolin can you give?
More. So working through the emergency algorithms and components for asthma, I don't know what burst therapy as well, you can provide 12 puffs every 15 to 20 minutes.
Great.
Which would
Lee, we'll stop
that and then stop it.
Hey, well done. How'd you feel?
Well, it's good in this situation. So a little bit less pressured, but I did feel that I was pushing forward with my answers and had to sort of calibrate myself and stop myself from talking too much. I think is a big thing for that is I thought my thoughts were ahead of where my words needed to be, and I needed to come back and go, okay, I need to come back to structure and work through. I definitely feel that I needed a little bit more structure in that assessment. My pre-induction meds for this person would probably entail a pre-medication, given if his asthma was fully controlled free, I would have given that.
You actually got out all the answers eventually anyway, so don't worry about anything extra. But no. I think your perception is right that you often had a lot of words there, and so this is not meant to be a harsh criticism, but you're obviously giving an anesthetic and you know how to give an anesthetic well. But in the exam, it's like it is playing this language game to know what needs to be said at a certain time, and that's what I'm here for, to tell you what the language is, right? And so there's a few times you might have said, I would. I'd turn up the FiO2, turn up the flows, and then a whole bunch of other words around that when I already know what you're going to do. The only active, useful things said there was 100% oxygen, turn up flows, and anything peripheral to that, I was wondering why you were saying that when I just want to know your management. So that, for example, that's a good example, right? Because you said I'd check the monitors, and if they were hypotensive, then I'm like, I'm not giving you that. Let's just stick to what we've got and complete that. So I can see that your mind is going exactly how you said. It's racing to other things, and that's fine. This is about honing that kind of skill.
And that's right. And I think that was a lot of that is me preparing to verbalize X, and it's trying to go, instead of going, okay, you said, so you notice that the SATs are low. 5 minutes in, I need to know where I'm at in my theatre. I'm trying to create that picture. And all you wanted was crank the flows, turn the oxygen up. Hey. So and I just got to get to that. But I think and even like I'm doing now, I'm talking to fill a space whilst my brain is processing those thoughts. And I think that sort of can dig me a little bit of a hole because I lose my time. I lose my space. And then I have to go off talk, and my brain's finally caught up, and I go, oh no, I missed that. I've got to come back.
Yeah. Hey, so don't worry about any of that. There's all these reasons why, but we're going to just hone on, what is effective and to get you to your mark, right? So in the assessment, the first thing is you had a long spiel at the start about I would want to check what the progress was. That could be shorter, okay? I would want to know the events that led up to it and collaborate history with the surgeon and previous notes. That's the only sentence you need. So I'm going to give you this recording. Check collaborative history, check the progress, check the last events. Done, okay?
Yeah.
The next thing is, if you've got a sick patient, what's the style of assessment you do with a emergency patient?
Yeah, so they're working through the doctor's ABC.
Beautiful. So the first words you say with, I'm going to do an ADE assessment because this patient's sick, mainly checking, vital signs. And I would then tell you vital signs are normal. So this is not your septic hypertensive patient. So now you've flagged that. You then correctly flagged history examination investigation. So good. Now, in that, you make a gamble, right? If this is going to be a proper full anesthetic assessment, then you might want to go through all that. I would suggest using the words, I would do my usual anesthetic assessment, but in this patient, I'm most concerned about how bad their appendicitis is. I want their full history of their asthma and any of the issues around the airway and the BMI. The 28, so BMI doesn't have the sleep apnea, OHS kind of hypertension, cardiovascular pathology. So I would focus on. So you correctly started going down the asthma path. I had to prompt you with that, which won't happen in the exam. Okay. So I want a detailed history of the asthma. And you said lots of good things. I want to know how long they've had it, what the triggers are, last time they were hospitalized, any ICU admissions. I want you to mention any steroid use for the asthma, what treatment they're on. And then examine their lungs would be the other thing to escalate, make sure they don't have a wheeze. So imagine I was doing that. I'd say, look, I'd get collaborative history, want to know the events. I would check the A2E assessment because it's patient sick, especially checking their vital signs, making sure they're not hypertensive or septic. And after my usual anesthetic assessment, history examination investigations, I'd focus on their asthma, the severity, instability, exacerbations, or everything I've just covered before. I'm concerned about their BMI as it impacts on maybe OSA, but probably not other complications of BMI at this age. And I would do a thorough airway exam, knowing that they're 120 kilos, and that can be a bit tricky for bag mask ventilation. So then we go on to, what is your airway assessment? Again, you can just make it really sharp. I think you mentioned a whole bunch of things about context, and I think I had to say, what is your airway assessment?
Yeah.
So it might actually be worthwhile you repeat, just as a strategy. If I ask you what's your airway assessment, you go, my airway assessment is, just like back in school, right? If you answer the question, you get it. And then you did a decent assessment, just too slow.
Yeah. I figured that.
Yeah. I want to know any past history of airway intervention and the notes. I want to check their general inspection, their BMI, any facial features. You could say that in just facial features that might cause any difficulty. Mouth opening, melon patty, neck extension, jaw protrusion, maybe neck circumference, thyromental distance. That's it. Yeah. And you've got the marks then, right? And then I would volunteer these things.
To looking through the concerns for, so those difficulties in, right. So that's why I think I mentioned that in my answer in the first preamble in that answer was, I was looking at the global difficulties that would make issue with XYZ. Yeah.
Hey, so the next thing I asked you was, what is your approach to a unspecific airway? And you could have said anything there. You could have said DAS guidelines. You could have said Canadian guidelines. And I'm glad you said vortex, because that's probably the well-known in Australia and the easiest one to explain. And I'll just put this picture up for the audience to see. So you could say this is just a model of managing an unspecific airway where you have these 3 lifelines and you're trying to maintain oxygenation. Yep. I would do in each lifeline, consider manipulations, adjuncts, changing size, suction, oxygen, and muscle tone. And so this will be one of those aspects of, I'm just going to ask you knowledge questions, kind of like, what are the complications of a spinal, or what are the, causes of hypoxemia, or something like that. And I just the knowledge elements. And I had to guide you down that a bit, which won't happen in the exam. But if you were to just say this, lifelines, blah, 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 oxygenation, maybe that's all you need. And if the examiner wants more, they'll go, oh, what are the things that you could do for each lifeline? And you go, well, for bag mask ventilation, jaw thrust positioning, maneuvers, adjuncts like nasopharyngeal. For all of these, I consider paralysis and positioning and suction oxygen flow, LMA size and type. I change the size and type. And for ETT, burp, bougie, different blade video laryngoscope. And you can, have a game changer, maximum 3 attempts at each section. That's the rehearse thing. It's, try to rehearse that. And, But, with that,
I think, sorry, you go on.
without having that recently in your mind, you did well to come up with that, but this is about the practice and, just be sharper every time. Sorry, you go.
No, that's right. And I think my interpretation of what did you want from that question, and I think I went down there. I can explain the vortex by going through every sort of thing, what the whole process is, but just seeing it as being that picture is going, okay, well, yeah, I need my manipulations, adjuncts, size, change, or paralysis, relaxation and things on top of that. And then you've got the
Lee,
oxygen.
just to clarify, right? So there's specific questions and the broad questions. Specific question is, what is propofol? What is the dose of propofol? Broad questions is, what is the vortex approach? And in each broad question, again, this is totally a practiced art. You've got levels of knowledge that, like, the vortex approach is an approach to unanticipated difficult airway where you have lifelines. The next level is each lifeline involves this. So for you to go down detail in something is also not the right approach. It's to headline and then list details. Because then the examiner can go, oh, the broad strokes, I can either move on, or the marking scheme is about the detail, therefore I'll prompt you for the detail.
Yeah. It's just, again, these are the things that I'm sort of trying to get at and work through by creating my scaffolding. And I think just creating that situation within my head and my thought process.
Yes.
So that becomes automatic rather than, all right, let's pull everything out and just go, here's the dump, which may not be where you need. And you just need those key points to tick the box. And I think
and it's just a lot of practice, right? I asked you what drugs would you give for induction? This is actually a very specific question. What drugs would you give for induction? I'm okay that you went, oh, look, I'm a bit worried about the fact that they've got appendicitis and they're large, but you gave me very reasonable drugs. You just took a long time to give them to me. If you just said, I'd give 150 of fentanyl, 200 of propofol, and 120, 140, whatever, rocuronium, because I don't want to because it's a rapid sequence, and I don't want to bagmask this patient because they've got a beard. That's the full answer. It took far too long to get to that. So there's something, again, in your mind that's saying that I need to give more information than is well. And maybe that's just a style of exam. Maybe you've been given another examiner's style which wants that, and I apologize for that, but then that could be my bias. But if I ask a specific question, the ultimate to that question would be, what factors would make you choose the drugs that you choose in this induction? That would require the answer that you gave me. Also sharper and faster, but this one was literally the drugs doses. So that's good. You get at the end of it, you gave me a reasonable drug doses. Great.
Just took too long to get there. Yeah.
The induction hypoxemia. So that you start off really well. This is the one thing I really want you to do is err on the side of getting help each time. You definitely told the surgeon to stop, which is also good, or you addressed that. Even we weren't in this yet, but that's still a good thing to practice. Help, ask the surgeon to stop. And then you said, I would immediately temporize. Great. Turn up flows and oxygenation. So it's fantastic because oxygen at 100% with it, flows of 1 liter is still not oxygen at 100%. So that's very good that you did that. The way I want you to go through this particular scenario of hypoxemia or high ventilating pressures, which it would become as well, is I would immediately turn up the flows, 100% oxygen, and then I'd switch to the bag to assess compliance whilst auscultating the lungs and checking the circuit. So in a second, you've done everything you do and you've got the diagnosis, because the diagnosis for hypoxemia is invariably in auscultation, and you get to the wheeze. I forget the order you said things in, but it was so much other stuff.
I jump backwards and forwards, and I do. And this is my structure type thing where I was trying to get out everything. And this is doing that as just not getting to the point. And I think
totally fine.
Get the information, it's just getting it out in a cohesive sort of manner that meets the sort of a structured response that gives you points in that bottom part of the rubric, I think.
So that's good. So you then very well gave Ventolin, and you gave lots of Ventolin, which is fantastic. And then I asked you another specific question, what are all the drugs you can give? And you had a good selection. You said, I can give IV adrenaline, IV salbutamol, IV magnesium. You mentioned atropine before, and you mentioned some steroids, which great. it's fine. In the advanced level question, if I was really, I don't know, depending on how the exam was written, I would need you to give the Ventolin, reassess, give Ventolin, reassess, like that's the level of reassessment, treatment reassessment that you'd have to do. But yeah, you got there. And it sounds like your knowledge is there. Like a lot of it just has to be honed. But I'm so glad that you have the bits of knowledge there. You knew what the vortex approach is. You knew a thorough asthmatic assessment, and I'm glad that all I'm telling you in this is I want you to say these words at a certain time, not that oh you don't know your words. So I'm very happy that that's how it is, because this one, what you've got to deal with is a lot easier than someone who doesn't have those data points.
Yeah. Okay.
Beautiful.
Yeah. No, it's just sort of, and again, this is why I want to do this. And I think, again, habit, long time sort of through and exposure to these type of situations, I've found myself having to, prior to this type of exam, justify my responses and justify my answers. So I fill a lot of space that may not be necessary. And I think that is that's a previous coping mechanism and a previous maladaptive strategy in that scope that I wanted. And again, why I've reached out to yourself.
Hey, Lee, so it's a really good thing to be able to justify. I definitely won't say that that's the wrong thing to do. Only justify when necessary. Kind of like if someone asks you to put on a seatbelt, and you go, what's the most important thing you do in a driving car? You put on a seatbelt. No one's going to ask you to justify that too much. But if you said, justify driving at 200 kilometers an hour in a 60K zone, you have to justify like that. Some things feel like they need justification, whereas other things are just, oh yeah, we agree with it. So maybe it's that confidence of in the past, when you're a junior, you have to justify everything. But as you get more senior, you more have to make correct decisions and just run with it.
Yeah.
Cool. Any other questions, Lee, before we wrap up the formal part of that?
Oh, no, I think it's just going through those things and just practice. And I think it's taking that and understanding the question, as you sort of said, with the specifics versus the broad, give me this, answer that question. And rather than, why am I justifying my answer? Just give the drugs that I'd use normally. Yeah. Work on that dose. And then sort of, if you came back to me and said, well, why would you do that? Or what are you doing? Or justify why you do that, then I can answer. And it's my, again, I think confidence in myself to be able to present that in that manner and this format that I struggle with. Whereas so in the emergency department, where I can work within that situation or work within my team in theatres, I have my words that I need people to do, my targeted, can you do this? I need you to do that. Those type of situations. And again, that recognition and call for help, especially in a scenario where I would sort of try and address a little bit where I could, and then do that call for help is something I call for help early, as per the crisis manual and the ICU or the Wellington crisis handbook and things like that we sort of have available too. And just going through those things that recognize, temporize, call for help, communicate effectively, and then delegate tasks.
Hey, these are all good things, Lee. Probably do a whole podcast just on that crisis manual. We'll probably wrap it up then. Thanks so much for watching and listening. ABCs of Anesthesia. Please share with anyone who might be interested in this kind of material, and we'll see you again next time. See you guys. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.